injury, and then afterwards, John, take your time. If there is time, then we move on to our next presentation, which is from my own team, and Stavros Kostais will present a short case on traumatic brain injury in the elderly. So it's kind of today's really extremes of age, really. So John, you're going to talk about two cases of pediatric traumatic brain injury between the wing mirror and the warehouse floor. So go ahead.
Thanks, Professor Jumper, and also to Rebecca for getting all the slides and everything organized. Can you hear me there okay? You can?
Yeah, we can.
Can I have the next slide, please, Rebecca? The first case, this is really two cases that were sadly fatal in outcome, but they arrived at their destination by rather different routes, and I just want to talk you through them. The first is a 13-year-old girl who on the 7th of April was crossing the street near her school. She just stepped off the school bus and unfortunately didn't look both ways, and she was hit by the wing mirror of a passing van and rendered immediately unconscious. She was attended to by the local emergency services. She was airlifted from the scene. Then it was apparent that she'd sustained a severe traumatic brain injury, but didn't appear to have any other injuries. So she was airlifted to the Temple Street Children's Hospital, where I saw her in the resus room there some hours later. She was flexing to pain. She had, with her left upper limb, she'd no movement on the right side, and her pupils were sluggish to light, but equal. GCS was 6/50, no verbal, no eye opening. And if we move to the next slide, please. If you could press play on that now, we might, I don't know if I can pause that. Can I pause that? We'll pause it just about there. You can see that she has, well, it looks like a very viable brain. There's a gray-white matter differentiation is preserved. She has a thin acute subdural on the left side with corresponding effacement of the left lateral ventricle. And given that she had reactive pupils, albeit sluggish, and she had semi-purposeful movement, she was taken immediately to the operating room. And I'll move on to the next slide, please. So I'll hold that just for a second, actually, if you wouldn't mind. So we at surgery, she had did a standard large traumatic bone flap on the left side, and the dura was tense and blue, opened widely, and the subdural hematoma sort of self-evacuated and followed very promptly thereafter by the entire hemisphere herniating out of the wound, out of the craniotomy. And so I introduced the intraoperative ultrasound and discovered that she had an interhemispheric acute subdural hematoma. She was given TXA, and blood products were administered as bleeding was profuse. But the hemisphere was extremely swollen, and I used a red rubber catheter to try to evacuate the interhemispheric parafalcine subdural, which seemed to work okay, but nonetheless the hemisphere was enormously swollen, and there was absolutely no way I could close this, let the scalp over the herniated hemisphere. So what I did, rather unorthodox, was I wrapped the herniated cerebral hemisphere, which is our dominant hemisphere, in saline soaked swabs, and wrapped her head up like a sort of mummy, almost like, and then we put her in the ICU. I put an ICP monitor in as well for what was worth, but her ICP was never an issue because the head was wide open. And then on day 4, so we just parked her in the ICU to see how she'd get on. Would she survive? And if you just play that cine clip there, please, Rebecca, you can see this is day 4. The much of that dominant hemisphere is extracranial, and it was clearly a situation that was untenable. So if we go to the next slide, please, we brought her back to the operating room. And so I stitched in a xenograft, it's a bovine pericardial graft. And in fact, I needed two of them. I needed to stitch the grafts together to cover the exposed cerebral hemisphere. This is after the graft procedure, just as essentially as a dressing, because otherwise her brain was exposed to the atmosphere, and it was just a bit of a mess. And so we returned her to the ICU, but within a number of days she developed a fever. It started to suppurate. There was pus evident. So we brought her to next slide, please. There's just another close-up view of the graft that was interposed. It was still not possible, even several days later, not possible to close the scalp primarily. We were looking down the barrel of having to do a hemispherectomy, really, to close the scalp, which was a thought that none of us really relished. So she had an MRI scan, which I should go to the next slide. And if you can scroll through that, please, Rebecca. You can see this is after the graft had been stitched in place. While the dominant hemisphere is now covered with a graft, it is not, still remains extracranial. So it was evident from this study, which was done day 6 post-injury, that that hemisphere was not viable, and with the presence of infection, really the only way to move forward was to resect the hemisphere. And this task fell to my unfortunately to my colleague Derek Crimmins, who had to do the unenviable task of resecting her hemisphere, which he had to do to primarily close the scalp. So we knew we'd sort of crossed the Rubicon. There was really no prospect at this point of any possibility of a meaningful recovery for this girl, because we see acute subdural hematomas with traumatic brain injuries with GCS6 not infrequently, maybe every couple of months, but we can generally anticipate a good outcome for these patients. But in this particular situation, it wasn't, and it just went from bad to worse. And we'll move on to the next slide then, please. So on day 8 post-injury, with a heavy heart, she was returned to theatre, and the left neocortex was resected, and the scalp was then closed primarily. So finally, we were able to close her head, but albeit without her dominant hemisphere, which was, really we're cutting off our nose to spite our face a little bit. So we move on then to the next slide. So this is a scan done 19 days later. So at this point, she was now, we can just might scroll to that slowly there and stop about halfway. A little more, a little more, a little more. There. So you see that not only is obviously the left hemisphere is decimated, but she has multi-compartmental contusional brain injury. This isn't an isolated left acute subdural hematoma with a beefy hemisphere. It was really a whole brain injury, though the right certainly looked in better shape. She was now, at this point, she was breathing, she was self-ventilating, she'd been extubated. She was, I think she had a nasopharyngeal airway. She had an orogastric feeding tube, or maybe an NG tube at this point, I can't remember which. And she was discharged down to the ward, to a side room, where she was receiving, daily or nearly hourly physiotherapy, and lots of input, nursing care and input and so forth. But at this point now, she was with us for over 3 months. It was apparent initially her parents were so relieved that she was alive, and as time passed, it became apparent to them, and they were eminently sensible people, that the prospect of recovery really was dwindling, or had dwindled, certainly, once we'd removed the hemisphere. which on the MRI scan pre-op had infarcted. So there was really nothing to be gained by keeping it at that point. We had a DNR order in place initially, because we felt that really there was no prospect of a meaningful recovery here. At her family's request, we lifted that DNR order after a number of weeks, because they were hoping against hope that things would gradually improve. But I know in my after a period of time, we got our palliative care team under the very able guidance of Dr. Fiona McElligott and she was heavily involved really in the management in the latter 2 months of her admission, when all sort of active measures had been exhausted. There was no ICP issues really they were really in the next case, which I'll discuss with you, but certainly the palliative care issues became paramount, and how that was handled and how it was perceived by the family. And I don't know if is Fiona there? Is she online there? No, anyway, well, I'll talk you through it. So we have a particular suite in Temple Street, which I hope we'll have in the new hospital, called the Butterfly Suite, which is essentially a self-contained apartment. And when it became really apparent that there was no prospect of any meaningful recovery, and all of our focus was on comfort measures and palliation, Aisling was transferred down to the Butterfly Suite, where her family could be with her day and night. They could cook meals there. They could have her friends in to visit, and they had a great time. Well, I can't say they had a great time. They had a very valuable time with her, and I think it was a very useful time. And at that point, she was being nourished with an NG tube and hydrated, but it was abundantly clear that she was minimally aware. There was occasional facial grimacing, occasional eye opening. She was essentially decerebrate, and it was after much discussion with her family, we felt that it was time not to prolong things unduly, and at that point the nasogastric tube was withdrawn, and within a few days she succumbed and passed away peacefully in the presence of her family. So, and her parents, I think, were immensely thankful that they had that period with her, because they gave them a rather softer landing than our next case, they were in hospital. You can go to the next slide, please, Rebecca. There. This is just post hemispherectomy, that you can see the multi-compartmental nature of her injury. Next slide again, please. That's day 19. And after 95 days, she succumbed. Really the sense, obviously the family were devastated at her loss, but they were, I think, very thankful that they'd had an opportunity to spend such valuable time and quality time with her in a private setting, which was the input of our palliative care team was hugely helpful here. And I think in other jurisdictions it may be a situation where she'd have, and we did discuss doing this, putting in a peg tube, putting the bone flap back in, all of these sort of longer term measures, which when you've only half a brain, are really fruitless, and sort of moving the deck chairs on the Titanic. So I think all things considered, it was the best outcome given the circumstances, even though initially there was no question that we were not going to operate on this girl initially. She had acute subdural hematoma. She was flexing. We just cracked on, and but the outcome was obviously fatal, but not, I think, the worst outcome. The worst outcome here would have been a persistent vegetative state in somebody who continues to be life is prolonged, perhaps unnecessarily. Okay, so that's our first case. If we might move on to the second then, please. The second, very different scenario. It involves a young male child, 11-year-old fellow. He'd an afternoon off school. He hooked up with some friends. They went exploring the locality, got onto the roof of a warehouse, and unfortunately found a weak spot, and he fell through the roof of the warehouse, landing on concrete floor about 4 meters below on his head, and he was rendered immediately comatose. The emergency services attended him at the scene. He had an oropharyngeal airway placed, an OPA placed at the scene. There was some question of whether there was seizure activity, and some midazolam was administered. However, he was never conscious. There was no purposeful movement from the moment of impact, and he was then airlifted to CHI Temple Street, where he was intubated in the resus department. He'd already received midazolam at that point, so it was difficult to assess. But certainly from the ambulance man's notation, there was no purposeful GCS3 from the outset, though the possibility of seizure activity was mentioned. If we can go to the next slide, please. This is his presentation scan within a number of hours of injury, and we'll just scroll through that. Oops, can we go back to the video? Is there a bit of video there? There. Now we'll stop about there. Okay. So, well, we'll show that again. And you can see that there's, again, multi-compartmental injury. There's a thin left acute subdural hematoma, thin right acute subdural hematoma, tentorial blood. There's bifrontal contusions. There's left temporal lobe contusions. And if you look at that image there that's captured, you can see that the lambdoid suture on the left is disrupted with extensive boggy swelling over it. If you move to the next slide, please. And this is just, this is upside down. I couldn't rectify, but anyway, you can see the left lambdoid suture is diastased. It's widely open. So, and that involves very considerable transfer of energy to do that. So, diastasis of a suture is would be an indication of a very severe impact. So what was our decision making here? I had to consider what our ceiling of surgical care was going to be. So I felt on the basis that he had a very poor primary GCS and he had a severe mechanisms of injury with multi-compartmental injury that I was not going to intervene surgically with him. So we would go with best medical management. And this is really where my colleague Dermot Doherty and his team in ICU came in. I'll just scroll to the next slide there just a second. So I don't want to steal Dermot's thunder here, and again, Dermot can step in anytime. Is he there? Is Dermot there?
Yeah, I'm here, John.
Hi, Dermot. So just from his notes, I could see that he received intravenous morphine. He had remifentanil, he had midazolam, propranolol. He received boluses of thiopentone, and now you can correct me at any time if I'm overstepping that. And we tried to avoid infusions of thiopentone as it accumulates in the adipose tissue and makes it very difficult then to make any neurological assessment thereafter. And rather different to the adult protocol, which I'll show you in a little while, the one that we have at Beaumont, we used inhaled isoflurane anesthetic as an agent. But do you want to talk us through that, Dermot?
Yeah, John, I'll put my camera on. So some time ago, maybe 10 years ago, the use of propofol in pediatrics was pretty much put on a moratorium because of propofol infusion syndrome, which is a metabolic defect seen by rhabdomyolysis, high temperatures, and acidosis. And so we've never really been in a place where we can use propofol for prolonged periods. So some time ago, we were in a situation where we would have these patients come in and they would be sedated with midazolam or an alpha agonist such as clonidine, more laterally dexmedetomidine, and a narcotic, which could produce a depth of sedation, but it may not produce the level of anesthesia that might be required for the most severe brain injuries. We've had experience since the 80s in pediatrics of thiopentone infusions, and it's something that is in textbooks that has it's still asked of us from time to time for either status epilepticus or refractory ICP issues. But while very effective in the short term, and what I mean by short term, in the first sort of maybe day and a half or up to 72 hours, the pharmacokinetics of the drug accumulates in particularly in muscle and fat, and predominantly and particularly in cardiac muscle, which renders the patient very difficult to manage from a hemodynamic point of view. And the kinetics being such that the drug takes days to come out of the system, even with the use of extracorporeal filtration. So we, in Temple Street several years ago, we were put in a couple on a spot where we had a number of patients that had a status epilepticus called fever-induced refractory epileptic seizures. And we had about 3 of them over a year, where we were in, where these children, adolescent children, were coming in and required deep sedation. And so we started to use our anesthetic machine, and then we trans over to a German device called an anaconda, which is attached to a syringe driver, where an inhaled anesthetic liquid is infused into what's essentially a HME device and vaporized into the patient through a normal ICU circuit. And we can measure the end-tidal concentration of the gas, which is not that accurate, so we go clinically from it, but we can induce surgical anesthesia with we've been using isoflurane predominantly because of the lower minimum alveolar concentration of isoflurane. So we put that into a protocol several years ago of what we, when do we use it, and we're really talking about third tier of ICP management when we're into a patient that has to be deeply sedated, that might have several boluses of propofol or thiazide used, or mannitol, 3% saline. And we're looking at sedating or anesthetizing the patient fully, plus or minus a narcotic, and also using muscle relaxant infusion. So we tend to use either atracurium or rocuronium, and these would be the severe end of the patients. In this particular patient, he came in very quickly after his ICP probe went in. He was having intervention after intervention by the team at nighttime of everything, which would be most of the kitchen sink with 3% saline, midazolam, narcotic, and other osmotherapies as well. And so he had been on the morning, I think, that my colleague had decided to put him on the anaconda. I think Aisling Walsh might be online. He was on 10 milligrams per kilogram per hour of propofol, which is way into propofol infusion syndrome territory for us. Our upper limit for sedation in propofol over a 12-hour period would be 4 milligrams per kilogram per hour. So we had to do something else. So he went on to the anaconda, and he was on the anaconda for, I think, most of his ICU stay, and along with some midazolam and a remifentanil infusion as a narcotic. And we would gauge his depth of anesthesia using an AEEG. So we have a AEG. We don't have CEEG capabilities, so we use basically a neonatal monitor to look for burst suppression in the EEG to establish anesthesia, and we would usually keep it on a MAC of 0.8 to 1.3 for isoflurane percent, and so I might hand back to John, because he might talk to the.
Sure, yeah. So in addition to the intravenous and inhaled agents, he was receiving regular boluses of osmotic diuretic mannitol and hyperosmolar therapy with triple normal saline, and so we were running into refractory elevations of intracranial pressure, and so we had in fact the 4 pediatric consultants had met on day 2. We might go to the next slide, please, Rebecca. And we had to redefine our surgical. Either we were going with best medical management up to this point, but there was some discord. In fact, we put it to a show of hands of who would decompress and who wouldn't. And our 2 more junior colleagues would have felt decompression might be indicated here, and the 2 senior people were reluctant to, but so we kind of compromised, and we went for an external ventricular drain as a sort of a halfway measure. And so he was too unstable to be moved to the operating room. So my colleague Dara Crimmins yet again stepped into the breach and kindly sited an external ventricular drain into rather small ventricles, but he managed to bring the navigation equipment up to the ICU and put an axiom guided EVD very neatly into the ventricle, which helped, I think, just overnight. But within by day 3 we were we were struggling again, and his EVD continued to work. It would empty. It would 3 or 4 mils an hour, and then we would be back into more refractory ICP issues. Next slide, please. So just this is the TBI protocol that we have in Beaumont, and I know some of my Beaumont colleagues are online. They'll be familiar with this one. I'm not sure it's the most up-to-date one, but it's not sure. So there's a number of tiers or steps that we use. Initially, we try to that's March 2012, so that's a little out of date. So I think there's a more recent one than that. But essentially, it's a ladder of intervention where you start off with the more basic measures, then move to the more nuclear options. Certainly, the external ventricular drain was at the higher end of the therapeutic ladder, and he'd maxed out on the medical interventions. The next surgical option was a full bifrontal craniectomy, and that is a very effective way of lowering ICP and almost ensuring survival. However, from the rescue ICP study that was done in the UK with Peter Hutchinson, whilst with decompression certainly ensures a greater number of survivors. However, you end up with a much greater number of very poor quality survivors. And I think all of us who've been around for any length of time will have seen poor quality survivors, be it in adult or pediatrics. And I think most of us would agree that a very poor quality survivor probably is a fate worse than death, and that it's not something that we would be keen to encourage. So next slide, please. This is just just from our pediatric ICP management. Now, we don't tend to ICP neonates or small infants, but there's a tabulated form of what ICPs one might expect. And so both of our patients from the 11 to 16 year age bracket. So you try to have a normalized speed sort of 10 to 15. You try to keep the treatment threshold less than 20. In fact, this fellow, I pushed it up to 25 because we were really struggling. And you try to target their cerebral perfusion pressures then with inotropes to keep it greater than 60. Next slide, please. So on day 8 post-injury, EVD was in situ at this point. We were struggling with ongoing ICP issues. We were fully sedated. Now, isoflurane, one of the unfortunate side effects of isoflurane is it gives you fixed dilated pupils. So, but you can't really count them as a neurological assessment because isoflurane causes it. So you're not really sure whether it's a physiological effect or is it a drug effect. Anyway, you can see from this scan very clearly that he has multi-compartmental injury. And if you go next slide, please. And here's the scan showing the tip of the EVD in the right frontal horn, which was again, it was working, but so we had somebody who was heavily sedated for over a week at this point, and with fixed pupils, and we really didn't know where we were. So we next slide, please. So we removed all sedation over a period of 5 days. And on day 5, it was clear that the pupils had remained fixed and dilated. There was no cough, no gag. So he underwent the first set of his brainstem death tests on day 13, second set on day 14, and he was declared deceased at that point and had organ donation. Now, obviously, so I think we've arrived at a similar outcome to the first patient, rather much more rapidly. The decision-making process was really, from the very outset, are we going to decompress or are we not? What's the ceiling of surgical intervention appropriate for this patient? And those are the sort of thoughts going through my mind, certainly on the night of admission. How far are we going to take this? Certainly I've seen a situation. I've been involved in a situation where very severely brain injured children have been decompressed and they're left decerebrate, and and whilst they linger for weeks and weeks and weeks, and it's really an awful situation to be in. So it's something that we try to avoid happening. So again, whilst yes, it's a fatal outcome, I still think it's the better better of the lesser of two evils, if you like. And that is that the end of it. Next slide, please. Oh yes, here we go. This is our CHI algorithm. I won't go through everything, but there's again, rather like the adult one, we have a number of tiers of therapy that we can escalate to, with tier 4, step 4 being the more nuclear options. In red there, it's obviously very serious. So it's and those are the sort of process that we go through. He rapidly ran into step 4 very quickly, pretty much on admission. I think that's next slide, please. That's us. Thanks very much. Any questions?
John, thanks very much. Two obviously very sad cases, but they kind of highlight the reality of severe brain injury, and kind of, it's a very honest, I think, presentation of what really happens. We often just cherry pick the really successful cases and present it in meetings. So it's good to look at the ones that don't do well. We probably actually learn more from them. A couple of kind of things I've picked out from what people have put up, and also my own. Interesting, your first case that you presented, the initial scan was kind of misleadingly good, wasn't it? I know there was a thing.
It was, yes, it was, and I was certainly surprised and dismayed at surgery when the hemisphere just swelled up like a souffle. In fact, it was, and so I got the ultrasound out to make sure there wasn't a collection. She did have a collection interhemispheric, but despite evacuating it, the hemisphere was hugely swollen, far beyond anything I've actually seen before. And because I've never not been able to close the scalp before.
Yeah, amazing.
But there was no question of closing the scalp. It was just now maybe what I should have done differently. Perhaps I should have put a graft in de novo at then and there. But it was kind of like a deer in the headlights. I wasn't quite sure what to do with it. So I just wrapped it up in saline soaked gauze and popped it back into ICU. But maybe anyway, it probably wouldn't have made much difference.
Yeah, but I think your two cases show the kind of dilemma we go through and the agonizing decision making about, do you do a decompressive craniectomy or not? So you showed that really well with the two cases, because in one you did it and the brain's on the floor and you can hardly close the scalp. The other one you didn't do it, and as you said, the outcomes were both actually fatal. And as you say, the randomized trials show that the decompressive craniectomy saved lives, but you end up with more severely disabled people, which is not what we want to do. So I think the problem is our selection criteria are still poor, and we can't properly decide who is really going to benefit and who isn't. That makes it really difficult.
And I know we recently had an ICU meeting in Beaumont with our colleagues there, and there was issues brought up, with the experience of the U.S. military or indeed the Allied military expeditionary force in Afghanistan, where TBI cases all get decompressed, without any discernment between one case and another. And we felt that that's really not the road we want to go down. I think the creation of decerebrate patients is absolutely to be guarded against, I would have thought.
Yeah. Ger Curley had his hand up. I don't know if Ger, do you want to come in or?
Thanks, Mohsen. Just really briefly, John. Thanks very much for those two cases. I think they illustrate the complex decision making and the agonizing that you do. I suppose two comments. So the first one is the Royal College of Physicians have a really good document on prolonged disorders of consciousness following sudden onset brain injury, and I just encourage everybody to read it. It talks about minimally conscious and vegetative states, and how we diagnose them, and it also has a really good guide on the withdrawal of artificial nutrition and hydration. And I suppose in the UK that is a little bit more straightforward. In Ireland, the legal and ethical framework around that is unfortunately not as clear, and there are times when it becomes really, really very complex around having to get word of court and a court order for this. But I'd encourage everybody anyway to read the document, because it's really very good about those very prolonged disorders of consciousness. And then just the second point is is in relation to inhaled volatile vapor. I was really interested to see it being used, and I completely see that you're stuck between a rock and a hard place when you have propofol at such a high dose. But the problem with inhaled volatile vapor in TBI is that it increases intracranial pressure, and that's why we have Anaconda here, but we wouldn't use, or we don't use it. So I wonder what you thought about it, and I'm sure Dermot's fully aware of the effect on intracranial pressure. What did you think about that when you were using isoflurane, or did you feel that that might have been a factor in the raised ICP?
Thanks, Chair. Most of our experience is that when they're fully anesthetized on isoflurane, that the ICP falls. Okay. We do transcranial Doppler in terms of looking at flows periodically. It's not always done, but we do look at it, and certainly in this case, we did transcranial Doppler and looking at the flows. Now, at the point in time, we were able to see two things by doing that. Firstly, we could see that the brain blood flow was hyperemic, and the velocity of the brain blood flow was the systolic velocity was about 190 meters per second, with a diastolic velocity of 120, which is way up for a child of this age. Now, a lot of that might be driven by inotropes, but I think it might reflect what you're saying, is that there would be a potentially vasodilatory effect, but that is usually negated by the negative inotropic effect of the isoflurane, because we're usually on inotropes, some degree of inotropes when you're on isoflurane, just to ensure CPP is good. As the injury involved, went back several days later, looking at the blood flow at the same MAC, and the velocity had come down from 190 down to about 90. And it changed as the pathology changes in these cases. So, just to answer your question, we don't. I can't say I've noted that there's been a raise in ICP when they've been on isoflurane, and most of the time I see that there's a fall in ICP, that we just get a better handle on it. And the cases that become refractory kind of glide into that over the course of several days. That this child, unfortunately, was right from the very beginning. But the kids that do evolve into increasing interventions for ICP management do so in the days following ICU admission.
Thanks, Jarvis. That's really interesting, and it's just something for us to kind of think about, because I think the data is all on just isoflurane alone. So it's really interesting that when you add in other agents, that you don't see that rise. And it's fantastic also that you've amplitude integrated EEG to look at seizures. That's really brilliant that you have a facility for 24-hour monitoring of EEG. Thanks.
Just to give my thanks to the ICU team in Temple Street for the extraordinary work they've done in these cases.
Yeah, I was about to say, John, actually the two cases showed the number of people involved and the teams involved in the care of patients with head injury, and sometimes the length of stay that they have to have in hospital. There's one question about the role of hemispherectomy in TBI, but actually this was a very, very unusual case, John, where obviously you couldn't close the skin otherwise. So that was the only reason that was done, and it's an unusual situation. So thank you very much, John, and the team at Temple Street. And I might just move on to the next presentation, if that's okay. Stavros Kostaios is going to present a case, and it'll be a short presentation on an elderly person. We're moving to the other extreme of age with TBI.
So if we move to the next slide, please. So this is a case of a 76-year-old man who had a mechanical fall with a head injury and a loss of consciousness at 17:30 on the 21st of September. When he arrived in the emergency department in Drogheda Hospital at 1800, he was GCS 15. So he dropped his GCS at 2000 to E4V3M6 with left hemiparesis and hypertension. So at that point, he had a scan. Can we play the video, please? As you can see, he has an acute subdural on the right-hand side, an intracerebral hemorrhage with on the frontal lobe on the right with midline shift and some early hydrocephalus. So he was referred to us at 2100 and he was accepted for transfer immediately. He has a background of end-stage renal failure on dialysis and a previous stroke. It was unclear at the time whether he was on any antiplatelets or anticoagulation. Can we go to the next slide, please? So whilst the team in Drogheda were organizing transfer, he further deteriorated to E1, V1, M2 with fixed and dilated pupils. He was promptly intubated, ventilated, sedated, and hyperosmolar therapy was instituted prior to transfer to Beaumont. When he arrived in Beaumont, he was bradycardic and hypertensive, GCS3, but however, he was on sedation and fixed and dilated pupils. So we repeated the scan on arrival to Beaumont. Can we play the video, please? As you may be able to see, he has tonsillar herniation, effacement of the basal cisterns, brainstem hemorrhages, Tourette hemorrhages, worsening midline shift, expansion of the hemorrhage, and further hydrocephalus. Can we go on the next slide, please? So given his neurological status and the devastating scan, it was decided not to proceed with any intervention. We discussed with the family about the poor prognosis, and he was palliatively extubated 12 hours afterwards and passed away within half an hour. Can we go to the next slide, please? Now, TBI in the elderly is a common referral theme on a daily basis at Beaumont Hospital. And in most instances, there is no acute intervention offered. And this is not due to an idiosyncratic whim of the neurosurgeons, but rather it's evidence-based surgery. So we conducted a literature search to determine the mortality rates and functional outcomes following TBI in this age group in order to demonstrate the rationale behind our decision-making process. So the Traumatic Coma Data Bank was a prospective collected database of TBI patients in the US that followed their clinical course of these patients. Excuse me. This demonstrated that there's an increasing probability of poor outcome with increasing age, which is also due to the associated medical comorbidities of the elderly patients, which predisposes them to medical complications following traumatic brain injury. For example, the majority of these patients have underlying cardiac or respiratory comorbidities, and they're either on antiplatelets or anticoagulation. Overall, this study demonstrated that irrespective of the mode of injury, elderly patients had poor outcomes compared to younger patients. So at 56 years and over with comorbidities was a point from where there was a steady increase in the percentage of poor outcome. A multivariate logistic regression model demonstrated that age to be an independent predictor of poor outcome after other factors were excluded. And at 6 months, patients over the age of 60, 92% of them were either dead or severely disabled. Can we go to the next slide, please? This UK study prospectively analyzed 372 patients with traumatic brain injury with GCS 13 or less. And from 50 years of age and onwards, age had become an independent predictor of mortality. Can we go to the next slide, please? These 4 class 1 articles from the 1980s and 70s documented greater than 75% mortality in severe TBI patients aged 60 and upwards. Can we go to the next slide, please? Moving on to more recent studies from this century, these systematic reviews and meta-analysis of mortality rates in older patients, these are patients over 60 with TBI, demonstrated similar results as the studies in the 80s, 70s, and 90s. The overall mortality rate is approximately 38.3%, and the pool mortality based on GCS for mild TBI, moderate TBI, and severe TBI was 12.3, 34.3, and 65.3 respectively. The second one, a systematic review in acute subdural hematomas in the elderly, traumatic ones, who underwent craniotomy and evacuation, demonstrated mortality rate of 49.3 at 6 months and severe disability of 79.2 at 6 months. As you can appreciate, these results demonstrate that based on the current literature, surgical intervention for traumatic brain injury in the elderly is associated with significant risk that must be weighted against the benefit. Next slide, please. Thank you.
Thanks very much, Stavros. That's very nicely demonstrated. And there's a few comments that I'll go through. And just to come back to the case, I suppose from the beginning that hematoma was quite big, and actually we weren't 100% sure whether some of this was related to a spontaneous intracranial hemorrhage. And that's one of the things in the elderly, sometimes when they have trauma, there's actually a preceding, say, intracerebral hemorrhage. They're on anticoagulants, as you said, or they're hypertensive, and they have, say, an intracerebral hemorrhage, and then they fall and bang their head, and it's not truly an isolated trauma event. It's also a preceding spontaneous hemorrhage. And we kind of said we'll accept him, even though the hematoma was quite large, and but his initial GCS was said to be 13 or 14. We weren't unfortunately aware that he had then deteriorated en route, and then when he arrived and his situation had clearly deteriorated significantly, and the scan showed a massive extension of the hematoma, including brainstem hemorrhage, then it was quite clear that any intervention would be inappropriate. And I think what you're showing in terms of the data, it's very, very convincing. Now, some people would say, well, if you don't actually intervene in these people, you never know whether they're going to do well or not. But there is quite a lot of data, as you showed, on also intervention in these patients in this age group, which show very, very poor outcomes with neurosurgery for severe TBI in this group of patients. And I think it's a nice follow-on to the audit that we presented sometime, I think just before the summer break, showing that the vast majority of people that we don't accept for transfer are people who either have signs of brainstem death on presentation, or they are in the elderly or very elderly group of patients. And 92% dead or severe disability. I think it's kind of sometimes heroic or unethical to operate on these people. And we have to be able to select the minority that might do well after neurosurgical intervention. The other problem with a lot of the data in the literature is that they just report the mortality rates, and they don't report what was the functional outcome in those who survived. And we know from our own practice that in these severely injured elderly people, often even if they survive, they don't have actually a good quality of life afterwards. And I think it's good to present it at this stage because there's a lot of data being presented all over the place, including published actually from Ireland, comparing the accepted patients for transfer to neurosurgery versus those not accepted for transfer to neurosurgery, and saying those that were transferred did better. Of course they did, because they were younger and didn't have brainstem death. So comparing apples and oranges sometimes leads to kind of misleading results and conclusions. If anybody else has comments or questions about any of the cases. Somebody says that the case was very high risk for transfer. Instead of transferring the patient, I would ask the neurosurgeon to come down and operate on him in the referring hospital. That might change the outcome of this patient. Well, I'll answer it, and I think other neurosurgeons can join in. Many years ago, a good study was done, actually, of, in fact, I think by Graham Teasdale, who invented the Glasgow Coma score, and they looked at this issue of neurosurgeons being kind of going in their car and going to other hospitals and operating, and the results were not as good as you might think. This is not the sort of surgery you can just pop in with a craniotome and do a burr hole or something like that and get a good outcome out of it. There is a huge number of people around us, including neuroanesthetists, neuro ICU. You saw in the case that Mr. Kerr presented, the outcomes are actually not so good when you go and operate in another institution, and that's why it's very, very important for neurosurgery to be centralized, and actually transferring the patient is a better option. This patient's outcome would have never changed because, in fact, what it looked like is a subsequent massive extension of his hemorrhage, which may in fact have from the beginning been a primary intracerebral hemorrhage rather than a traumatic hemorrhage. Any comments from my colleagues? Would you have? Oh, Stephen, yeah.
Sorry, I'm not sure how to use this properly. So Northern Ireland did this actually quite a long time. Dermot Burns, I was his last reg. He unfortunately passed away recently. And they were doing this into the 90s. And the results were, they stopped doing it after they were doing it longer than anybody else. And the reality was it ended up just kind of going down to Derry and doing a burr hole, because you need a whole setup with nurses, the appropriate things, and you need to transfer the patient anyway. So the idea of rushing around the country dilutes it, and really the outcomes are very, very bad. And as you know, and for those who don't work in neurosurgery, you need to be in a neurosurgical theatre with experienced people with the right equipment. It's not a case of just bringing down a set like it was in Adams McConnell days with a jiggly saw and taken out a clot. So no, it all has to be centralized. It's the transfers and the speed of transfers and the quality of the transfers that's the vital thing.
Yeah, I think that's a very important point, and actually early intubation, maybe on the scene, and early transfer is what we really need to be looking at. Very good. I don't think I have other comments or questions, and we'll wrap up there. And as I said, the next meeting is on the 2nd of November at 6 p.m. again. And again, if other hospitals want to put up cases and we can discuss them, I'm at mjabatpour@rcsi.ie, and you can email your case and we can see if we could present it at these meetings from non-neurosurgical centres as well. Great. I'm going to say goodbye unless anybody has burning questions. That's perfect. Bye-bye. Have a good evening.